Thank you, Joe. Never a good position to follow Chris. But hi, everybody. My name is Isaac Vetter. I work at Epic. I work on tools and standards that help developers build apps on top of Epic. By app, I mean things like CDS services, embedded Smart on Fire applications, even content that can be imported into the EHR and used by clinicians, or content that can be imported into our patient portal and used by patients. So I'm a simple interoperability software developer. I don't have much background of the VHA, and so I apologize for any gaffes. I appreciate you're letting me be here to speak with you. So I'm going to talk through some of my thoughts of empowering veterans through self-service tools, telehealth, and interoperability with community health systems. And I want to tell a little story. It's a little of a trivial story compared to some of the other examples that we've heard today of interactions with veteran patients, but it's also my most recent interaction with my own healthcare system as a patient proxy. So earlier this winter, my wife and 16-month-old son and I got to visit Florida, and he developed a rash, and we were a little bit worried about it. And we're in Madison, Wisconsin, so a little bit far away, but pretty affordable flight from Miami. And so I thought that you wouldn't actually want to see a rash. So I went with this adorable picture with some pigeons. So this is our little baby. And through my Madison-based health systems patient portal, I can kind of do all the things that you'd expect and all the things that we talked about. So things like view and share my record, so meds, all clinical data, request a refill, see all the apps I've authorized to. That I or he, I guess, has authorized to connect to his medical record, message my provider, schedule an appointment, and also on-demand video visits. And so we ended up kind of conducting an on-demand video visit from Florida back home, which I didn't even really know existed before that, and I thought was actually pretty awesome. And so when we talk about, I think Don's kind of comment this morning of, do we really need scheduling? Is maybe purposefully controversial, but also kind of maybe we're thinking a little bit about how we do on demand, how we provide access and resources to medical care in real time when possible. And so I just wanted to kind of share that. So I spent a lot of time thinking about what state-of-the-art scheduling, patient scheduling really means. And so I kind of came up with three different properties that I want to work through. And some of these there's a lot really packed into them, and I want to see if we can spend a little bit of time unpacking some of these things, as well as maybe do a better job engaging with the audience, with you guys, during this talk than we've been doing otherwise this today. And so please interrupt at any time. So first, tightly integrated. So we've used the word interoperability, we've used the word integrated. That's in the name of this panel. Both of those words are. We haven't really talked about what the word integrated is, although we did a good job, Joe did a good job talking about definitions of interoperability. I'd like to suggest that tightly integrated really means at least two things. It means that a scheduling system is tightly integrated with that clinical system. So the EHR is the scheduling system. The clinician's user experience, the scheduler's user experience is seamless. It's easy. They're not switching between applications. They're not switching between windows. That risk score from the suicide hotline is displayed in the same application on the same patient's chart when that scheduler is making an appointment. So that's what integration means, and that should be the goal for this project. Similarly, the clinician's experience for that on-demand video visit, are they switching to a separate application, or is this happening in their EHR? How is that how does that workflow, how is their clinical workflow streamlined? How is that software a joy to use for that clinician as part of that kind of complicated thing where it's really easy to bucket video visits into their own separate thing, right? But, and so then the question I think that, you should be asking Cerner is, how is that clinician experience seamless? How is that clinician experience enjoyable? Then the exact same thing applied to the patient. So is my patient portal, is that how many apps do I have as a veteran interacting with the VA? Do I have a kind of read-only clinical app? Do I have my telehealth app? Do I have, I'm getting like the voicemail or text message reminders. So what's that kind of consumer experience, and is it as in it, and how seamless is it? And so I think tightly integrated, and both from the perspective of both clinicians, kind of schedulers and employees and users, as well as veterans, should be a goal. Is an attribute, is a core characteristic and functionality of a state-of-the-art patient scheduling system. It communicates with veterans. We kind of already talked about that. I think that some of the things that we heard today about Annie, are exactly what the rest of the industry are doing well, because it's effective, right? The patient reminders in the way that the patient wants to receive them is how you is a practical and effective way to decrease no-shows and increase engagement, and is a state-of-the-art capability. And then interoperability. So Joe defined a couple of different levels of interoperability. I think that I wrote them all down correctly. So from my perspective, we have kind of inside a health system, we see scheduling interoperability happen via HL7 version 2 messages, kind of flowing through some interface engine back and forth between applications within that health system. We see open scheduling APIs, the kinds that are well used by companies such as Kairos and ZocDoc, who we're talking tomorrow morning, who enable consumers who don't have a previous relationship with a health system to easily schedule appointments directly into a health system themselves through just a public website. So those two things, V2 and those open scheduling APIs, are technologies that we've been using that the industry in general, I think, has been using for, I feel like, a fairly long time. And then when we talk about organization to organization, I think organization to organization scheduling, interoperable scheduling, is really a lot more of an emerging capability, and hasn't been around in kind of a mature and reasonable way for very long. While the exchange of health record data through HL7 version 3, through IHE and CDAs is mature. I think we've been, as an industry, I think that we've been doing that pretty reliably for, I don't know, maybe a little bit under a decade. But that's always been the exchange of kind of static health information. And I think then that's a mature capability within the confines of that CDA document. When we start to look at cross-enterprise scheduling, the technology that we've been using and would encourage others to use as well is a FHIR-based technology. And I'm going to talk through that a little bit. So despite Chris's comment about HL7 FHIR, I'm going to say rah rah HL7 FHIR. So anyway, at least for API-based interoperability, where that technology, where that use case is both profiled and well used and adopted across different health systems, different types of health systems, I think FHIR is very clearly the right technology to enable a specific kind of business use case. We've seen the common clinical data set of in HL7 FHIR become extremely common over the last 4 or 5 years. One of the particular I also just wanted to kind of give a brief definition. FHIR is a modern, lightweight interoperability standard created by the HL7 organization, deployed by many healthcare organizations, as well as CMS and the VA developer portal as well. The Argonaut Project is a collaboration between providers and health IT developers towards the goal of advancing interoperability using APIs. Each year, the Argonauts have selected a handful of targeted and important interoperability needs and kind of created, refined, and implemented and tested and released FHIR profiles. In calendar year 2017, the Argonauts created a FHIR scheduling implementation guide that defines a number of different use cases, among them cross-enterprise scheduling using FHIR. It's a relatively simple integration. There hasn't been a ton of industry support for it. It's something that we've been using between different health systems that use our software for a little bit. It is just published on the internet. Our specific implementation uses the Smart Backend Services Authentication and Authorization layer, which is just kind of a simple profile on top of OAuth. Let me know if anybody wants more of that kind of information. So simple flowchart here. So there's the ability to kind of find, to match to a patient and or to create a patient. Do an appointment availability search, get back slots, optionally like issue a slot hold command, and then finally to kind of book an appointment, and then also the ability to exchange kind of patient clinical data. So this is a standardized thing that got created in a really collaborative way across a number of different healthcare IT vendors in 2017, and that's being used in production now. I think that when the VA looks and as Cerner looks to implement interoperable cross-enterprise scheduling with third-party community systems, I think it's hard to argue against this being the best technical method to do so. I'm going to skip that one. Okay, and then I also wanted to just kind of quickly plug a second kind of in exactly the same kind of space, a technical integration profile that's really in the process of just getting created even this summer by that same group, but by some really intelligent, capable, and effective people. To use a FHIR subscriptions model. So this is kind of a pub-sub model is what they call it in IT, where I, as maybe as an app or as a server or as a consumer or as a PCP, can subscribe to specific content on some server out there and then get notifications when that content changes or when that criteria is met, maybe when some event occurs. And so one of the things that we're looking at in the Argonauts group this summer is using that FHIR subscriptions kind of capability to enable the ADT notifications that's kind of described in the CMS proposed rule. And that's a project that's where we're actually just right now kind of creating the spec, still super early. And I just wanted to kind of put it on the radar as maybe something to watch that's relevant in this space. And I think that Sognic's actually going to kind of fill us in on some of the maybe more stable technologies that do similar things, but that aren't quite as cool because they don't have a flame. All right, so overall, kind of talk through some of that tight integration. The API-based interoperability, I think should use existing profiled and implemented FHIR implementation guides when we're looking at APIs. Overall, this is maybe a little controversial. I think for both the VA EHR modernization project and the VA enterprise scheduling project, in general, we have to walk before we can run. Smooth, streamlined, and basic functionality should be the initial focus. And once that's solid, then that's the time on which to build some of the really awesome things that we've heard about today. In general, I'd encourage the VA to make sure that to get your money's worth from Cerner. Like, there's a lot of capability there. Use it. Their functionality is going to be well integrated with itself, and so whether or not you build that integration manually or whether or not you buy it off the shelf is kind of the decision point there. And then as part of that, there's also going to be like multiple decisions over the next 5 to 10 years as to whether or not existing national systems get consolidated into this enterprise rollout, or whether they get integrated, and whether and when does one decide the first versus the second, and then also in the case where they are integrated instead of consolidated, is there the appropriate budgeting and time for that to happen? So that's maybe not the best place to end, but that's where I'm going to end. So thank you, everybody.
Thank you, Isaac. I don't know if you've maybe time for one or two questions. Yes.
Hi. So I'm Lisa Lehman. I'm the Chief Medical Officer in the Vision One, the VA New England healthcare system. And thanks so much for your presentation. I think that your question of what do we mean by an integrated system is really worth spending some more time fleshing out and thinking about, and John did do a phenomenal job of spelling out what we mean by interoperability and raise the question, I think, of what's the value of an integrated system. And let me just give you, I guess, a little bit of perspective from the field in the VA, because in Vision One, we have been trying to develop a clinical contact center, what we call a clinical contact center, and clearly the scheduling piece of that is the first point of access for our patients. And the vision that I've been trying to sort of put forward is that clinical contact center not only schedules patients, but resolves patients' clinical problems at the point of care. What I mean by at that point of care, when they call and want to schedule a visit, that there's someone who's asking them what is the reason for their visit that they want to schedule, and if it's a relatively minor clinical issue, that we have a nurse practitioner, a PA, someone with clinical expertise in the scheduling system who's coordinated and integrated not only with the schedulers but also with our EHR, so that person can resolve the need immediately. Clearly, there needs to be that kind of integration with our EHR, which Eva mentioned earlier today, too. The other pushback here that I just want to raise is that as we've tried to move from, we have this name of a Veterans Integrated Service Network, and I've been shocked to find out that we're not really integrated, even within a region, let alone having interoperability and integration throughout the entire country. And when within our vision, we've been pushing for a unified clinical contact center for all of our facilities and are moving forward with that in primary care, but have had a lot of pushback from the specialty care providers because they want to schedule within their clinics because they feel they know the services that are available, they know the patients, and they can do a better job of it. So I think it goes also to the point that Chris was talking about in terms of decision trees. And I'm wondering if those are maybe if Mayo's as open source as John in terms of sharing those decision trees. And then, the challenges I think that we need to do as the VA in terms of figuring out some of the decision trees and what are the services that we offer that may be unique that may not have been developed by Mayo or others. So I just throw those out there, these issues out there with the hope that as we move forward, we're going to try and develop some solutions to these problems that I think are really going to result in a high-functioning, efficient system.
And those are great comments. And before I move to John, I think one of the things, Isaac, go ahead. I think the theme that you're also hitting upon that I think as we move to Sagnek's talk as well too will be the fact that I think there is a growing recognition that any contact with a patient, customer, you name it, is an opportunity. It's an opportunity more than just to doing the task at hand. We're talking a lot, our internal medicine team is using the medication refill opportunity as an opportunity to close lots of other care gaps that may be apparent, but that means the person doing the med refills needs access to all the other care gaps to be able to do that and take advantage of that touch. And so in many senses, I think broadening the thinking and making sure there is not information siloing in that in just the scheduling system per se, I think it is an important construct to bring forward. So, John?
So just two quick comments. So can you hear me? So tomorrow we're going to have session 6, which is actually going to tell you why this fire thing is important, where it came from, and all the rest. Everything Isaac said today, just don't worry. It's foundational and important background for tomorrow's session 6. In case anyone wants to relive the experience, Fire and Argonaut was invented at the Agora restaurant. It's 1 mile away from here. Great hummus. We were all feeling Greek. That's why we called ourselves the Argonauts. Anyway, the quick comment is you heard both from Chris and Isaac, what may have sounded like slightly different opinions on this fire thing. Just what they were getting at. Don't worry, they're not different opinions. It's that unless an organization builds business rules as to what app can do what, the amount, as Carolyn told us this morning, the electrons flowing back and forth doesn't help you so much. So if Epic, let's imagine, has this great thing called the App Orchard, and it's got all kinds of extraordinary VA-specific apps, but the VA doesn't enable the workflow to change those apps, we don't accomplish anything. So I hope tomorrow what you're going to hear from a whole group of experts is the importance of changing workflow as well as implementing these standards.
And that's big and importance, I think, recommendations for our committee coming from a bunch of people that are really interested in the technology side of things. So, yeah. All right. Sidenick. Sorry, Chris, go ahead.
Yeah, this is Chris, if you don't mind me commenting. I want to double down and triple down on what John Halamka said. I completely agree. Isaac and I think, completely agree on the future of fire. I would take it one further, which is to say, where I tried to end it, be careful what you ask for. The fact is we're actually going to modernize healthcare. And I think that is absolutely fantastic, and I can't wait. But it's going to be a little bit messy when we do it, and we should absolutely do it. With respect to the question about open source, we've had a lot of people come look at our decision trees, and frankly, they're so bespoke and custom to us that they're not particularly usable by others, but we've explained the theory over and over to lots of folks, and other people who want to come visit us, we would be happy to share. The one thing we did put in the pseudo-open source domain, and I don't want to put Isaac on the spot, but we spent a lot of time with Epic engineers describing what we wanted in terms of all the peculiarities of our decision tree management, and they really revved up Cadence to be able to do that, and therefore it's available to any Epic customer.